Thanks very much, Sylvia. Well, we're moving forward this morning, and I think we've got a wonderful program for you following a wonderful program yesterday. Our first speaker is going to be talking about nutrition to promote healthy aging, and his name is David Reuben from the David Geffen School of Medicine at UCLA. And what we're going to do is have Dr. Reuben speak, and then we'll go on and have some discussion, and then go on to the other speakers. Let me just introduce Dr. Reuben. He's director of the multi-campus program in geriatric medicine and gerontology, and also chief of geriatrics at UCLA in the Center for Health Sciences there. And he's also Archstone Foundation Chair and Professor at the David Geffen School of Medicine at UCLA, where he directs the UCLA Alzheimer's and Dementia Care Program. In addition to his leadership role there in geriatrics, he continues to provide primary care for frail older persons, including making house calls, and I know you did some of that yesterday, I guess. Come on up and please come and speak.
Thank you very much for inviting me. If I weren't here today, I'd probably be at home sleeping. So, in any event, there we go, we got it. I'd like to spend some time talking a little bit about some general principles about aging and nutrition, and then I'll talk about some of the dietary measures. I realize I'm bringing coals to Newcastle here, since you folks probably know a lot more about this than I do, but I'll try to put an aging slant on it. And then I'll speak a little bit about nutritional supplements, and then at the end, as a geriatrician, I'd like to pose some questions for the field. So older people are more heterogeneous. As we get older, we're different folks. I'm going to tell you a tale of two comedians. I live in Los Angeles in kind of a pretty wealthy community, and a lot of kind of Hollywood stars and people like that are my patients. And I have two comedians, and one of them is 87 years old, and this guy is still on the road. He's still touring and such. And then yesterday, the last thing I did before I left for the airport was I saw one of his pals who had just been hospitalized and was virtually comatose. He had normal pressure hydrocephalus, and he was 82. So you take a look at two, and then on Sunday I did make a house call. Monday night I made a house call to one of my patients who's 90 years old, who's about to make a commercial for a presidential candidate. She and her daughter, who's a celebrity, is going to make her an advertisement. So there's tremendous diversity that you see in older people. The risks associated with malnutrition also differ. As people in this room probably know, that being a little heavier as we get older is not such a bad thing. It may actually be protective. Some studies have shown that. And a lot of what I face as a practicing geriatrician is really undernutrition. I can't get calories into people, and particularly as they get older and frailer, keeping weight on is a big issue. The barriers to good nutrition also differ. The one I think that is the most important that we see in older people is functional impairment. And when you start to, in fact, some of the ADLs and IDLs, such as preparing food, going shopping, and feeding yourself, are all things that become impaired as we become older and frailer. Oral health is also a particularly important barrier in older people, particularly because they lose teeth, and that affects what they can eat. The other two I'd like to mention are chronic diseases that have dietary restriction. I have a patient who I'm just having a miserable time with because she's got kidney disease, and her potassium keeps rising. And she's also not eating very much, and I hate to restrict her dietary intake because she's going to starve, but she really can't eat potassium or else she's going to wind up in the hospital. And finally, medications. The medications we give older people, and they take a lot of medicines, frequently interfere with appetite. Occasionally they'll cause weight gain, but most of the time they actually interfere with appetite. The other is that nutritional health and problems may vary by subpopulation. So younger and healthier older people, in not too many months, I'm going to cross over from being middle-aged to, by Medicare, old. And I would argue that my nutritional needs now are not going to be much different than they are next year. But the other hand, we have people who have chronic diseases and people who are frail and have multiple chronic conditions and limited life expectancy. And then finally, setting, where you are, whether you're in the community, whether you're at an assisted living facility, or in a nursing home. So I've actually, one of my interests, and one of the things I do a lot is population health, and I think about the older population, and I've drawn this schematic here. So if these are all the old people, you have, I don't know if this guy works or not. Nope. Ooh, my goodness. There we go. So you have these people who are not sick, functionally intact, people like myself and many of the people in the room who may or may not have chronic diseases such as hypertension or diabetes or asthma. Then you have the sick people or people who are functionally impaired and who have multiple chronic conditions. And then you have people who have end of life. And these are all people who are community dwelling, but they also go into the hospital, or they go from the hospital to the nursing home, and from the nursing home back home, or from the nursing home back to the hospital. And you see there's a lot of movement there, and the nutritional disease requirements for each of these populations and in each of these settings is different. So I'll talk about some diets and some evidence for older people. The three I'm going to talk about are Mediterranean, DASH, and the MIND diets. So I presume pretty much everybody in this room is aware of this, but just to create a slide to show some of the differences, the DASH diet, which is the dietary approach to stop hypertension, and the Mediterranean diet have a lot in common, but there are a few little differences that are in italics here. The DASH diet has low fat dairy, whereas the Mediterranean diet recommends low full-fat dairy, and then fish is a little bit different, classified a little differently in the two diets, but by and large they share a lot of the same principles. Similarly, the MIND diet, which calls itself actually a blend of the DASH diet and the Mediterranean diet, is operationalized a little bit differently, more nuts and more berries as part of that, and some things drop out. There are two kinds of data that support these diets. Observational data, mostly looking at cohorts that have been studied and have had dietary questionnaires and food frequencies, et cetera. And when you look at these observational data, these diets look pretty good. Some of these are from meta-analysis, and if anybody's interested, all the references are on the bottoms of the slides and annotated. Reductions of cardiovascular disease by 9%, cancer, two different meta-analysis from 6 to 10%, with significant effects on colorectal, prostate, pharyngeal, esophageal, which was the biggest. Decreased overall mortality, and one that I'm particularly interested in is that Parkinson's and Alzheimer's disease were reduced by 13%. There have been a number of other single studies that really show that these diets do just about everything for you. Protect against chronic kidney disease. I saw one on depression. There's one that I saw that keeps your car clean for the next 6 months. I mean, these are just amazing diets. The MIND diet is this combination, and some folks out of Chicago who have been studying this for a number of years. They looked at a cohort who was at risk for developing dementia and followed them for about 5 years when they published these studies, and showed that the MIND diet, these were people who, they weren't prescribed a MIND diet, but they adhered to a MIND diet, had less decline in global, episodic, semantic, and working memory, better perceptual speed and perceptual organization at 4.7 years, and probably even more impressive that they were less likely to develop Alzheimer's disease at 4.5 years. Remember, these are observational data. This is not a trial. There have been some trials of Mediterranean and DASH diets. The PREDIMED study is probably the most famous, and this was a study that looked at people 55 to 80, so these were getting to be older people, and they randomized in one of 3 arms. The first was the Mediterranean diet plus extra virgin olive oil as a supplement, Mediterranean diet plus mixed nuts. That's the group that I would have chosen to be in, and regular diet that emphasized reduced dietary fat. And that was essentially the control group here. And the primary outcome was a composite outcome of MI, stroke, and cardiovascular deaths at 4.8 years. And what they found in the study, it reduced the outcome, the primary outcome, by 28 to 30%. And curiously enough, the effect size was the same for whether you're a young older person or an older person. There have been lots of data on the DASH diet and trials showing that it lowers blood pressure and also lowers cholesterol and other dividends from that. I have a particular interest in cognition, and in fact was in this building a couple of years ago when we did an IOM, it was IOM at the time, report on cognition and aging. And one of the interesting papers that was published around that time was another secondary analysis, the PREDIMED trial, which showed that the same intervention, extra virgin olive oil plus the Mediterranean diet or mixed nuts plus the diet, these folks had higher mini-mental state scores and clock drawing tests at 6.5 years. There's also been a short-term randomized clinical trial of the DASH diet, which showed better psychomotor skills at 4 months. Nutritional supplements. So this is what the party line is right now for calcium and vitamin D. U.S. Preventive Services Task Force has no recommendation. The Institute of Medicine, which is still the recommendation that gets cited most commonly, recommends 800 international units of vitamin D3 and 1,200 milligrams of calcium per day total if you are 71 years of age or older. There was no recommendations from the U.S. Preventive Services Task Force about vitamin, mineral, or multivitamin supplements to prevent heart disease, and there is a recommendation against beta-carotene and vitamin E, much to my chagrin because I took vitamin E for many years until it got discredited. And the U.S. Preventive Services Task Force do not recommend those for prevention. So the calcium supplement. The calcium supplement controversy, this is a huge war about what calcium really does to you if you take it as supplements. And there may be a difference between whether you're taking it as supplements or whether you're taking it as increase in your diet. The Women's Health Initiative did not show increased risk for heart attacks or for strokes, but there was a meta-analysis which did show a slight increased risk. Risk ratio of 1.3, and this, if combined with vitamin D, 1.24. In August, there was a study that was published in Neurology, and the way I found about it was reading The Week. And every week in The Week they have something called the Health Scare of the Week, and calcium made it in there. So I went and looked at the article, and it was a very small observational study done in Europe that showed that the odds ratio, if you were taking calcium supplements, for dementia was 2.1. Stroke-related dementia, it was higher, And probably the one most intriguing aspect about this study, and remember this is a very small study, less than 1,000 people, that showed that if you had a prior stroke, if you had a history of a stroke and you were taking calcium supplements, the odds ratios approached 7. Multivitamins. Observational data, this was the Women's Health Initiative again, postmenopausal women showed no benefit of multivitamins for breast, colorectal, endometrial, lung, or ovarian cancers, no protective effect for MI, stroke, venous thromboembolism, or mortality. There just was no there. In middle-aged men, this is another, I believe this is a meta-analysis, multivitamins have not been shown to decrease cardiovascular disease or mortality, but there was a slight reduction in total cancer risk. And there's been several studies looking at infections in nursing homes and in outpatient settings, and the multivitamins have shown no benefit. Last year, the AREDS 2 trial came out, and this was a very large trial looking at supplements or fatty acids and antioxidants and zinc. And the purpose of this trial didn't have anything to do with health, it had to do with eyes. And it was actually trying to prevent progression of age-related macular degeneration. But while they were in there doing this study, they did a very large set of cognitive tests. And unfortunately, these supplements, any way you cut and slice them, they didn't show any benefit on measures of cognitive function. So a few questions for the field. One is there are U.S. dietary guidelines for people, including older people. One of the questions is kind of how these can be promoted and included in prevention and healthcare settings. In medicine, in healthcare systems, almost nothing is going on with nutrition in older people in terms of advising them. We don't even have those discussions about good nutrition, and how can this be promoted? How can the unique barriers to good nutrition that affect older people be overcome? And here we talked about settings and we talked about populations, but I have to tell you this is just a bad story that if you are in a nursing home, and there are some nursing homes who will not even accept patients who don't have G-tubes. And the reason why is the amount of labor costs it takes to time spent feeding people who are in nursing homes is just not in their business model. So how to approach those kind of very difficult populations in those kind of very difficult settings? Is the evidence for the Mediterranean DASH diets compelling enough that these should be implemented widely, and if so, what is the best strategy? In preparing for this talk, I kind of just Googled DASH diet and such like that, and there were a few little articles in some of the health magazines, but there was no big national campaign, and I would say if you go out on the street or walk down the hill and ask people what a Mediterranean diet is, they probably wouldn't even have any idea of what you were talking about. I would think it's probably some weight loss strategy. What can we recommend for people who are not appropriate for these kinds of diets? These are the people who are frailer, have multiple chronic diseases, and in particular, the group that I see a lot are people who probably aren't going to live long enough to accrue the benefits of something that has its biggest bang for the buck 10 and 12 years later. So we're talking about shorter term, people who have 3 to 5 year life expectancies. And finally, I think this is the last slide. What are the appropriate stance on multivitamins and other nutritional supplements that don't have evidence? So I have to tell you, I prescribe a lot of medicines. I prescribe a lot of medicines because my patients have a lot of diseases. But if you take all the medicines that I prescribe for a patient and match them with the supplements and the memory enhancers and all these things they buy at the nutrition store, you're essentially doubling the number. And it's just unbelievable. Some of the smartest people I've ever met are taking some of the stupidest preparations I've ever seen. And the question is, how can we get, I don't know whether they're poisoning themselves or not. Frequently I'll say, bring them all in, let me take a look at them and tell you anything that you shouldn't be taking. But there's enormous amounts of money being spent on this and without any benefit. When, if ever, is it reasonable to stop preventive nutrition measures? When do we say, geez, nutrition is not your big issue other than getting some calories into you and eating whatever you like? I have a number of patients who graduate into that category of eat anything you want, because it's more important to get something down them than it is to try to limit what they take. And finally, I think maybe with coming out of these 2 days is that what more do we need to know? What would be the research agenda for older people with nutrition? What kind of studying each of these populations, studying what works best for them, what new knowledge needs to be created, and how best to apply what we know. This whole area of implementation science sometimes lags behind, and I think for some things we probably are ready for more implementation science work. Others, it's still nutritional epidemiology and clinical trials. So with that, I'm going to stop. I'm right about at my 20 minutes, and open it up for questions. Thank you.